All right, let's get started. Good evening, everybody. Welcome to the Online Prosthetic Bootcamp. This presentation is the first part of a four-part series, and today's topic is Single Implant Crown Restorations Playbook by Christopher Resnik. So we'd like to welcome him. This is in conjunction and partnership with the Mish Resnik Implant Institute and ITX Pros Academy. So I'd like to welcome each and every one of you guys. Just a little bit about ITX Pros. We are, your guided surgery digital lab partner, where we help you with treatment planning, surgical guides, all on ITX cases, as well as radiological interpretation. So we're a digital lab that provides you with turnkey solutions so that we can help you with treating your implant patients and cases. Today we have Dr. Christopher Resnik, who is a grad of the University of Pittsburgh School of Dental Medicine. He's also, his specialty is in prosthodontics, so he went to residency at the University of Pitt as well, dental medicine school. He has a master's degree in oral implantology from the University of Pittsburgh. He has an inactive diplomate with the International Congress of Oral Implantologists. He is a faculty member at the Mish Resnik Implant Institute, as well as in the Resnik Implants Hands-On Bootcamp. And if you haven't tried that bootcamp or signed up for it, it is a must-do. And then also he is a contributing author at the Mish's for the Mish's Contemporary Implant Dentistry 4th edition book, as well as the Avoiding Complications in Oral Implantology. As well, on top of all of that, he has a private practice in Winter Park, Orlando, Florida. So with further ado, we have Dr. Christopher Resnik.
Thank you, Robert. Appreciate the introduction and everything. Real quick on the panel today, we have Robert from ITX, the Chief Academic Officer. We have AK, the CEO, Hussein, the CCO, and Sarah, the Clinical Director there. We also have Tara, one of the faculty members at the Mish Resnik Institute, that will be answering questions throughout there. So I appreciate the introduction, and we have a lot to cover today, so we'll jump right into it. The agenda today is we're going to kind of cover everything that goes on from when that patient comes into the office ready for the implant restoration. So when you see them 3 to 6 months after the implant's placed, what do we do? How do we get them the restoration? So we'll talk about the integration of the implant, how to check that, how to improve the accuracy of the final impressions to limit complications, some of the important instructions that you want to put on the lab script, the ideal insertion protocol, as well as the ideal occlusion for implant restorations, and then also touch base a little on the implant maintenance for these patients. Like our previous ITX webinars, this is going to be an interactive webinar. What that means is we'll have a series of questions throughout the webinar. I think we have 5 or 6 this evening. So what will happen is we'll get to a slide where I'll ask a question, and then you'll have around 4 or 5 different choices here that you'll be able to select. One of a poll will pop up here, just like this. You'll be able to select your answer, and then after a couple seconds here, we'll see what everybody's answer is, and then we'll go through the question there. So an interactive webinar there. And then throughout, if you do have any questions, down at the bottom or top there, there's a Q&A or chat. You can type the questions. One of the faculty members will answer it throughout. And then at the end, AK can ask me any questions that were unanswered throughout the webinar here. Additionally, either later tonight or tomorrow, you will be getting a CE credit emailed to you from ITX Pros for this webinar. So with that being said, we have a lot to cover this evening, so we'll get right into it. So we're going to go over the single implant crown restoration and a little playbook that we put together here. So if we look at single implant crowns and what used to be a success and what is termed a success now, in the past, it was a success if that implant was still in the mouth. So it didn't matter how it looked, but was that implant still in the patient's mouth? And unfortunately, where we're at today, that is not the case. Now patients come in and they want a tooth that looks like their natural tooth that they had. They don't want it to anybody to know it's an implant, it has to be functional, aesthetic, and phonetic. So that's kind of where we're at right now, where the success is nobody should be able to tell that it is an implant. So how are we able to achieve that? First, let's talk about some of the problems that can happen with single implant prosthetics and some of the complications that arise here. So this is a list of some of the complications that can arise from just single implant restorations and just restoring them. So we first have premature loading, so loading the implant too early. We have results of an inaccurate impression where the crown and abutment do not seat or they're at the incorrect timing. We have implant crowns with poor emergence profile where they have a black triangle or lack the soft tissue drape, as well as poor aesthetics. We have retained cement causing peri-implantitis and bone loss. We have force factor issues such as broken screws, broken abutments, screw loosening, occlusal overload, fractured restorations, peri-implantitis. So this is all things that can happen from just restoring a single implant. And this is what we want to avoid here. So if we look at the studies here, this is a study that looked at up to 15 years post-prosthetic complications, and 65% of the cases had at least one complication. That's rather alarming. So over half of the patients that got implant restorations had a complication in those 15 years. Over half of them were biological, such as peri-mucositis or peri-implant disease, but about 30% of them were technical problems where the prosthesis was fracturing, you had screw loosening, force issues there. So rather high complication rate there. If we look at implant success in bruxers, a large amount of the people out there have some sort of parafunctional habits. Survival rates for somebody that has bruxism is down to 70% after 5 years. So what we think of implant success as being in the high 90s, if that patient has any parafunction, it's a lot less. And that needs to be taken into consideration and kind of planned for in the restoration. Screw loosening used to be much more of an issue back in the 90s with the external hex implants, but still, even this study looked at it here, and after 2000, screw loosening ranged from 3 to 10%, which is still rather a high percentage there. Proximal contact loss. This is something nobody really talks about, but it's all throughout the literature. This is the first study is a systematic review that was done in 2021, and about 40% of implant crowns had proximal contact loss. The lower study was a lot higher at 58%, but that's still a large number where, over time, you're going to be seeing that patient in maintenance and they're going to be packing more food there or, complaining of that. And then we have peri-implant disease, up to 50 mucositis, up to 50% of patients, or peri-implantitis, about 25% of patients. So these are the long-term complications that we're going to run into with implants. And then if we look at the maintenance here, this study looked at patients that weren't on a maintenance schedule. Their peri-implantitis was 11-fold there. So that's something that we want to, even for just a single implant, we want to implement in the practice there. With that being said, I broke down the single implant restoration playbook into 5 different phases here. And these are the 5 different phases that we're going to cover this evening here. And with that, complications can arise at any phase there. So it's important to kind of stick to this, or at least view this when you're restoring single implants, starting with the integration all the way until the maintenance phase of the implant here. So getting into it, when that patient returns 3 to 6 months after that implant's placed, how are we able to tell if that implant is ready to restore? So generally they're coming in after a 1-stage or a 2-stage approach. They're coming in with the healing abutments already on, or they're coming in for their recovery. With that, we first need to understand how that implant is healing and what is taking place over those months. So we have 2 different terms here, one being primary stability, the other being secondary stability. Primary stability is going to be the mechanical engagement of that implant at placement. So that's going to be how fixated that implant is the bone at placement. Secondary stability is going to take place over those next couple months, and through bone regeneration and remodeling is going to be how fixated that implant is when they come back for the restoration there. So that's where we're looking for the osseointegration there. If we look at a chart looking at the stability factors throughout those couple months here, you have a a big stability dip around the 2 to 6 week mark there, where the secondary stability is taking over the primary stability. So that's where the bone remodeling is taking place there. So that's when that implant is going to be at its weakest. So that's one of the points where we want to avoid going into that implant there. But not every implant is ready at 3 months. There's some that take longer. There's some that are ready before that. So it's important to kind of have a protocol or understand how we're able to test to make sure that implant is integrated. So these are 4 of the more common ways that we're able to evaluate implant healing and determine if that implant is ready for the restoration. With that, we'll start with our first question here. So which of the following methods has been shown to be the most objective and reliable for testing the integration of the implant? We have radiographs, insertion torque, reverse torque, or resonance frequency analysis. Okay, perfect. Good. So we have 66% with resonance frequency analysis. Good. So that's the correct answer there. So we'll go through each of these and figure out why that's the most objective and reliable. So first, radiographs. What's the issue with radiographs? The majority of the time we're dealing with a 2-dimensional film there, which with the angulation is going to pose an issue, because unless you take every image at the exact same angulation, you're going to have some sort of deviation. Additionally, with the 2-dimensional film, we don't get the buccal lingual dimensions there. And we know with bone loss on implants, it starts from the buccal there. So we're not getting anything from that buccal. So it's a lot of false positives and false negatives. With 3-dimensional CBCT imaging, we usually get an artifact around the implant called beam hardening. So that's the one on the bottom right there, where it looks like you have no bone on the lingual of that implant. That's just the artifact from the metal of the implant there. So you get a lot of false positives and false negatives with CBCT imaging. So radiographs are great, but they don't give us that much information on the integration of the implant. If we go into the insertion torque is what we torque that implant in at the time of placement. That's not going to give us anything with the secondary stability. That will be the primary stability there. So when that patient comes back, we're not able to test the insertion torque at the time 3 to 6 months later after that implant's placed. So that just gives us a reference with how fixated that implant is at the time of placement. Now looking at the studies and what an ideal insertion torque is, it's kind of like a roulette wheel. Every study you read is going to have a different number, and there's many factors involved, such as the type of implant you're placing, the type of bone you're putting it into. So really, insertion torque isn't going to give us anything on whether that implant is ready for the restoration. The reverse torque test is an older test where pretty much you put a implant driver in the implant and test it to a certain Newton centimeters to see if it disintegrates there. So every time I kind of hear this test, I kind of cringe, because it's all or nothing. You're kind of closing your eyes and just hoping that implant doesn't come out and end up in your hands there. So it's also very risky, because in some poor density bones such as D3 or D4 there, the implant could be integrated and it may torque out just because it's in soft bone there, something like a styrofoam or balsa wood. Additionally, you're going to be putting a lateral torque on it there, which will also kind of create an added torque to disintegrate that implant. So resonance frequency analysis is going to be our best and most reliable way of testing the integration of the implant. There's two main companies out there that have RFA. One is the Austell, the other is the Peng one. And pretty much what it involves is you put a little, what's called a smart peg or a transducer into the implant, and using a little handheld device here. So I use the Peng one. This is one of my cases here, where it looks like a little curing light here, and it'll say send little oscillating wavelengths through this transducer here, kind of like a pitching fork there. And depending on the fixation of that implant in the bone, it's going to give you a number based on the ISQ scale, or implant stability quotient. And that number is going to correlate to how stiff that bone or implant is within the bone. So we're able to use this test at the time of placement. We're able to use this test when the patient returns 3 to 6 months later. And we're also able to use this test 10 years down the road when somebody comes in and they have some bone loss around their implant. So really, it's a great way to test the stability. This is a chart here. The ISQs go from 0 to 100. 100 is going to be the most stable implant, where 0 is going to be no stability. Generally, for an implant to restore, we're looking at something in the high 60s, low 70s is generally it there. So, and the literature supports using RFA here. It's this study looked at it, and the most objective and reliable method for measuring implant stability there. So at this time, we've kind of checked on the integration of the implant. Now that implant's ready to restore. So we'll go into the final impression here. So 2 different ways. One is the conventional, using some sort of PBS or polyether. The other is the digital way by using scan bodies here. So to start, our goal with taking the implant impression is we want to obtain the most accurate representation of where that implant is in that jawbone in relation to the neighboring teeth there. So how are we able to improve the accuracy of the restoration prior to the impression? So what are we going to look at prior to removing that healing cap and taking the impression? So these are the 3 big things that I look at before taking that restoration. So I'm going to look at the opposing occlusion, the adjacent teeth and contact points, and the soft tissue drape. So if we go through these first, looking at the opposing occlusion, we want to get rid of all the plunging cusps there. So the one on the left there, where you can see that it's super erupted down there, and the one on the right there where they've just lost the vertical there and they're actually hitting the healing caps there. We can't restore those implants with where those teeth are right there. So this is what's going to happen if we do that. So the crown on the left there, you see the bone loss on the implant, and up where the top red area is, you see where that plunging cusp is just coming down, hammering that restoration, resulting in the bone loss here. We also have the fractured implant up there, and then we have a crown right here on the bottom right. This is one of mine that patient was referred to me, where it's a zirconia abutment, where actually the abutment right here was left in the implant. So why is this happening? Force-related issues. So not taking the opposing occlusion or that patient's parafunctional habits into consideration. Next, we want to evaluate the adjacent teeth here. So we don't want a point contact here. Having a point contact is going to lead to a lot of food impaction there and eventual bone loss there. So what we want is to create a broad contact here. So with that, we'll go into our next question here. According to some of the latest literature, approximately what percentage of patients report food impaction with implant crowns? A, 5%, B, 10%, C, 25%, or D, 40%? Okay, very good. So 54% chose 40%, so that is correct. So looking at the study here, they actually report over 44% report food impaction between their implant prosthesis and natural teeth there. So almost every other implant restored, that patient's going to report food impaction. That's a very high complication with implant restorations that really we should be discussing with the patients when restoring them, in ways that we can help limit that. So what's the cause? The majority of the time it's coming from the contact area, and that's one of the consequences here of having a point contact. So having food impaction, additionally having proximal contact loss, and then also difficulty in seating the crown because of the line of draw there. So the way we prevent that is creating guide planes. So on every one of my implant restorations, I'm taking out a burr and smoothing out the adjacent teeth to try to create a broad lung contact for that implant restoration there. So that's how we limit the amount of food impaction and contact loss. We're next going to look at the soft tissue evaluation here. So we want to look at the soft tissue drape, whether it's excessive, insufficient, or ideal here. And we have different ways of treating it on each of those scenarios here. So our goal with soft tissue is to develop an ideal emergence profile. We don't want to have cases that come in like this. These are both cases that actually were sent to me in the past month here that are kind of on each different sides of the spectrum here. You first look at the one on the left, you can see the big black triangle there, the screw access hole from the front. And then you look at the one on the right there, and it's, it takes you a little bit of time to look at it, but then you notice, the little triangle here. So these are, both problems, but both kind of different types of problems here and there. So that's where it is. So we want to eliminate having complications like this because unfortunately, now where we're at, these are both not successes. They're failures and they need to be, fixed there with new restorations. So first, what is the emergence profile or angle? This is the contour of the tooth or crown as it emerges from the soft tissue. And this is something that's able to be contoured to create more favorable soft tissue profile here. So the importance of the emergence profile is it's going to maintain the gingival health, prevent plaque or biofilm retaining areas, allow for proper oral hygiene, and most importantly, the aesthetics of the restoration. So if we first look at the emergence profile on natural teeth and compare that to implants, this is a pretty famous study back in the 80s by Kroll here, where he looked at natural teeth and wanted to figure out if they were convex, concave, or straight, the emergence profile. And what he found was straight emergence profile for natural teeth. Now, with that being said, implants are a little different because the implant we're placing is about half the size of what that natural tooth root is. So we're going to have to shape that a little differently. But in an ideal situation, the implant emergence should mimic the natural tooth there. So how we're able to create that emergence profile is through crown contours, and we're able to shape it different ways to train the tissue in what we're looking for there. So what are some of the factors that affect the emergence profile? Probably one of the biggest ones here is the implant size. So having a smaller diameter implant is going to allow for a more ideal emergence profile. It's going to give us more running room. However, you then run the risk of having biomechanical issues. Larger diameter is going to be much more difficult to obtain that ideal emergence profile. And problems with over contouring restoration. So the one on the bottom left there, where the implant's just not placed in the correct position, and then the restoring doctor has to make a kind of wild looking crown there. You're going to have difficulty in hygiene. The biofilm is going to accumulate there, which is going to lead to implant tissue, peri-implant disease, food impaction. So that's what we don't want to do. So how do we form an ideal emergence profile? So we have what's called the standard healing abutment. This is going to be a straight healing abutment. That's really not going to give us any emergence profile. The better ways of doing it are through these three here. So one is using a profiled healing abutment, the bottom left here, where it is profiled to shape the tissue and push it to where it will form a papilla for you. We can use an interim abutment or use an immediate restoration. And then the other is going to be a custom healing abutment. So a lot of people are using these custom healers now. This is a kit from Cervico by BPI, where it's very easy. And, with that, you're just able to shape the tissue to where that final restoration, that would fit the restoration. So not every implant site is going to be made the same. So the benefit of having these custom healers is you're making a healing abutment for that spot. You're not just making it in a generalized fashion there. So with that, let's go to the next question here. What is the ideal emergence profile for an implant crown? We have convex, concave, straight, or all of the above. Okay, good. So a little bit of everything there. That was a tricky one. So The answer is all of the above. We're going to create an emergence profile that's going to fit each restoration there. So, and I'll take you through a really good article here. This is an article by Gomez Meda out of Europe here, which is a really good article, and he kind of goes through all the different designs for the abutment here. And what he did was he broke it down into 3 different zones here based on where you're at in that implant restoration. So we have zone C, zone B, and zone E. So zone C is going to be the crestal bone stability up here in the green here, and that's going to be where the connective tissue is. And we're going to want that to be straight in an ideal situation. And then we get into zone B here, the biological boundary area, where the junctional epithelium is, and that's going to be dependent on the implant position, the soft tissue thickness, and that will either be convex or concave. And then we have the aesthetic conditioning area, and that's going to be the topmost there, where we're going to try to maintain the free gingival margin and present recession there. So looking at this crown here, we actually have all 3 here. So we have it straight coming out of the implant restoration. That's going to limit the pressure on the hard tissues and prevent bone remodeling. We then go into the bounded zone there, and it's either going to be concave or convex, and that's going to depend on where that implant is placed. So if it's placed a little too buccal, it'll be concave. And if it's placed a little more lingual or palatal, it'll be convex. And then in the aesthetic zone, it'll be convex, and that'll support the free gingival margin and prevent bone or recession there. So it's a really good article. Gomez Meda, they're just kind of describing it. But, with that, each restoration we're doing isn't going to be the same there. So, it's not just every single one we're doing is going to be convex, everyone's concave. We have to kind of look at the situation and see what we need to do with the tissue there. So now that we've evaluated that implant site, we now are going to move on to obtaining that accurate representation of that implant position. So these are our 3 different methods for restoring a single implant. We can use a closed tray impression, open tray impression, or a scan body. So what are some of the complications on taking impressions? The big complication is taking it inaccurately. What's going to happen if we don't get a accurate representation of that implant? We're going to have a non-passive fit or a non-seated restoration. We'll have poor contact points. It'll either be open or tight, a crown and malocclusion, the incorrect timing of a restoration, or a poor emergence profile. So how do we improve the accuracy? So we'll start here by just going through the conventional impression techniques. So that's going to be the open and the closed tray here. So if we're taking conventional impressions, what are some methods or ways that we can increase the accuracy to limit complications there? One is going to be to perforate the impression tray. So we want to put holes throughout the impression tray. What that's going to do is it's going to increase the retention of the impression material, which is going to cause less distortion. Another way is to use tray adhesive. So, like we were talking dental school, put tray adhesive inside the tray there. That's going to lead to better strength and allow less distortion of that impression material. We're then going to also modify our impression copings here. So this is going to be an open tray impression coping where before removing the impression, you have to unscrew the screw holding it in there, or the insert there. So one of the ways is through mechanical increasing the retention here. So the companies have gotten better, but still you'll open it up out of the box and it'll be glazed, shiny, but that's not going to help material adhere to it. There are some undercuts on the one on the left there, but so what I do here is I'll take it into the lab and I'll take a disc and a burr and I'll just kind of nick it up there. So I get rid of the shiny stuff there, and that's just going to create more mechanical retention there, roughen it, create more undercuts there to just help that material adhere to it. Another way is you can put adhesive actually on the impression coping. Now we're only going to do this with open tray impression copings. You don't want to do this with closed tray. But by adding the tray adhesive to the impression coping, when you insert that light body impression material around it, it's going to adhere a lot better to that impression transfer than it would if you didn't. And this is validated by the studies that show that roughened and adhesive coated impression coatings show lower amount of rotational errors there and bind to the material a lot better there. When dealing with closed tray, One of the ways to improve the accuracy is to block out the screw hole there. So with a closed tray, we're relying on removal of that impression coping after the impression and inserting it into that impression accurately there with the little screw head at the top there. If it's not lined up the correct way, it may not go all the way down there. So one way to improve the accuracy is to just block out the top of the screw channel there to eliminate that from preventing it from seating. Looking at the studies there on what we can do with open and closed tray impressions, and we'll cover this more at the future webinars here on the full arch. But this is a good systematic review that just kind of summarizes it here in when dealing with less than 3 implants, open tray is just as accurate as closed tray. However, when dealing with greater than 3 implants, open tray is more accurate than closed tray there. And from my personal experience, when I'm doing things the conventional way, I'll do everything open tray just because I have the validation that impression transfer is going to be in the same spot that it was in the mouth there. Since we're removing it in the impression tray, I don't have to rely on myself or worse than that, a lab tech putting it in the correct position there. So generally, I've found that you'll have much less potential for error when using an open tray impression coping, even for single units there. Now we'll go into digital impressions here. So everybody's going digital now. So these are with scan bodies. Those are the impression transfers that we insert into the implant, and then we take a scan of them. So with that, we'll start with a question here. For digital impression scan bodies, which of the following results in the greatest accuracy? The tallest scan body possible, the most distinct scan region, the roughest surface, or an irregular surface? Okay, very good. 54% most distinct scan regions. So that's the correct answer there. So we'll go through these with a couple studies on scan bodies here. So first, when we're looking at a scan body here, there's going to be 3 parts. We're going to have the base, the body, and the scan region. The scan regions is always going to be the top part of the scan body here, and the base will be what goes into the implant. Capturing that scan region is going to be the most important aspect. That's going to register the orientation and the angulation of that implant. Looking at the studies here, this study looked at several different types, and this one said that the scan body should have a distinctive scan region. So something that's going to identify where that implant is within the bone and the soft tissue there. So we want a scan body with a distinctive scan region. We also want one that's shorter and simpler shaped. So the idea of having it shorter there is similar to when you're thinking of scanning in the dentulous segment there. It's tough for the intraoral scanners to merge different points there. So that's kind of the difficulty when you're doing a large segment there or a bridge there. So that's why having a shorter scan body there is going to be more accurate, because you don't have to come up away from the gingiva as much there. So having something shorter and simpler shaped is going to be more accurate. If we look at the studies on conventional versus digital studies, there's a lot in the literature, and a lot of it kind of contraindicates itself here. So we'll go through some of the studies here. This one looked at implant impressions, digital versus conventional. For quadrant scanning of implants, digital was just as good as conventional. However, when we got to the long span scanning, conventional was greater than digital. This one looked at implant trajectory and the accuracy of implant impressions. When you have parallel implants, conventional are just as good as digital. However, when you're dealing with angulated implants, digital are actually better than conventional. And then if we look at the 3D accuracy, this is probably one of the most recent ones by Papasperdokis. it's a systematic review there, and they found that digital impressions are equal to conventional impressions. However, the majority of the literature out there is based on in vitro studies. So their conclusion on that was we do need more clinical trials to have complete validation of that. So a complete summary or a quick summary here on what the literature states. The majority of the studies out there are in vitro studies, and they have shown that digital are better. That makes sense because we're not dealing with blood, saliva, the tongue, the cheek. You're at, sitting at a lab bench there. So they found that digital are better. However, if you look at the in vivo studies, there's not many of them, and they're kind of 50-50, whether digital is better than conventional is better than digital, mostly being because it deals with the patient, where that implant is, and the person scanning it there. So if you were to take a scan, if your assistant was going to take a scan, you're going to have two different scans there. They're not going to be 100% there. So there's a lot of inaccuracies there. So kind of when looking at digital scans, it's going to depend on the scan body using, the intraoral scanner, probably most importantly, the patient factors, and then also even the scan strategy that you're using is going to impact the accuracy there. Okay, now that we've taken the correct impression and got, the location of that implant, we'll move on to the lab prescription. So these are some of the things that I include on my lab prescription: the abutment type, screw versus cement and retain, the material, the location of the crown margin, and the occlusal scheme. To just cover two of the ones that I see being problematic from what returns from the lab, and things that you guys should be looking out for before inserting it, the crowns. So we'll start here with the abutment type. There's many different types of abutments out there. Each lab's using their own abutment. Each crown or each type of implant has their own abutments there. So the abutment types are very variable. But kind of one of the main things that I look for is the engaging versus non-engaging. What that means is this is going to be at the base of that implant abutment, and that's going to be what's going in the implant there. So engaging is going to have the hex there. So that's going to engage the internal hex of that dental implant, where a non-engaging abutment is not going to have a hex there. So it's going to be smooth and not have any indexing device or seating so it can be seated at any way there. So what are indications for it here? So looking at an engaging abutment, this is going to be one that has a hex here. This is going to be only for single unit crowns. So we need something that's going to kind of hold that restoration in place and just allow it to go in one way there. So when we prescribe for a engaging abutment, that should be for a single restoration. Non-engaging abutments are going to be for multiple implants. This is using a non-engaging abutment. We don't have the hex at the bottom. So what we're doing is we're bypassing the internal hex of that implant. So where those red lines are, that's going to be the limit of the restoration. So we're not going to be going down into the hex of the implant there. Reason being is we will never have two implants completely 100% parallel within the mouth or even on a model there. So by using a non-engaging abutment, we're able to seat that restoration passively. We're never going to get two hexagons going in to two different implants completely passively there. So that's why we want to use non-engaging abutments when restoring multiple units. So this is non-engaging on the left here and engaging on the right. So one of the first things that I see with labs here is they'll give you a non-engaging abutment and they'll cut off they'll have nothing that's going down into the implant there. So if we look at the one on the left here, they cut the hex off, then they also cut half of the conical connection of that implant abutment there. So we're really not engaging anything on the internal aspect of that implant. What that means is that screw is taking on all of the force there. So we have nothing going on the internal aspect there. What we want is a non-engaging abutment that does go down into the implant and engages the inner walls of that implant. So that implant is taking part of the force, not just the screw there. So that's one of the first complications I see with labs. The second are them sending you back cases where they're both engaging abutments. So these are two cases of mine that happened within the past 2 or 3 months here, where I pull it out of the box here and I look at it and you see the hexagons at the very bottom or the top there. So those are both engaging abutments there. And what you don't want to do is figure that out after you've tried to insert it in the mouth there, because from doing that, you can A, damage the abutment, or B, worse, damage the implant there. So always examine the case prior to inserting it in the patient's mouth. So that's one of the things that I look for when inserting multiple units there. The next thing I'm going to include in my lab script is going to be the crown margin. So where should the crown margin be? Should it be at the crest, subgingival, supergingival? And the lab's able to dictate that because they're designing the abutment as well as the crown. So through the CAD/CAM software, they have all the control in that. So we being the dentist, we've seen the patient, we should be the one that is telling them where we want that margin to be there. So looking at the 3 different locations here, we have the top being supergingival. That's going to be non-aesthetic. We have it at the level of the gingival sulcus. That can also be non-aesthetic. Or we have it subgingival, a millimeter below the gingiva. That's going to be our most aesthetic option there. So if we look at the studies, where do we place it? Kind of all the literature supports this, that the margin should not exceed greater than 1 millimeter into the sulcus. Reason being is they've found that margins deeper than 1 millimeter, it's relatively impossible to remove all of the cement. And we know through the literature that cement leads to perimucositis and periimplantitis there. So we do not want the margin to be greater than 1 millimeter into the sulcus. Why is this such an issue? So what's the difference between a natural tooth and an implant? It's going to be the connective tissue fibers here. So on the left there, we have the tooth. On the right, we have the implant. So with natural teeth, when you're seating a restoration and all that excess cement comes out there, the hydraulic pressure builds, the cement moves out of the crown there and through the gingival sulcus. Well, the connective tissue fibers are perpendicular around the teeth, and those are going to act as a barrier, preventing the cement from traveling deeper. So rather than penetrating deeper, those fibers are going to stop the cement and actually shoot it back up to the sulcus where it's easy to detect and remove. With implants, those CT fibers are parallel and do not actually attach to the implant. So we're lacking that protective mechanism. So when you're seating the cement retained restoration, all that excess cement goes subgingival and it gets pushed further because it does not have any protective mechanism to come back up towards the gingiva there. So it's very difficult to obtain that excess cement when it's subgingival there. So kind of in quick summary here, the crown margin is dictated by the aesthetic demands. In the anterior, we obviously don't want to have a supergingival margin. So that's generally a case where I'll place it 1 millimeter below. In the bottom are actually 2 cases that I inserted this afternoon here in the posterior, where I actually had supergingival margins there, just because they're in the posterior and they were not an aesthetic matter there. So easy to grab there. Okay, now that we've written our lab prescription, we'll move on to inserting the crown here. So first, we need to look at the differences between a tooth and an implant here. So when you put a force on a tooth, the periodontal ligament is going to act as kind of a shock absorber there. We do not have that with an implant. That implant is fixated in that bone, and you really get relatively no movement there. So implants are not the same as teeth. If we look at the studies, and this is an older study here that looked at putting force on a tooth versus putting force on an implant, it validates that again, where the tooth is going to have some sort of give, where the implant is not. Once that force goes down there, there's got to be a weak link there. So looking at the impact force there. So with that being said, what is the ideal occlusal scheme for a single implant opposing natural teeth? Do we want that crown in infra-occlusion? Do we want it in timed occlusion? Do we want it in balanced occlusion? Or do we want it in group function? Okay, very good. Timed occlusion. So 65% got that there. So first we'll start with implant protected occlusion here. There's a really good online series through Glidewell that my father wrote here. So it's a 4-part series looking at implant protected occlusion that you can log on to, and they'll actually give you CE credit there that goes through this. But to just kind of give you a quick summary here, when we're restoring an implant, we want all those forces directed over the implant, and we also want to limit the shear forces there. So we want a narrow occlusal table, which is going to help guide the occlusal forces apically. We want to reduce the cuspal inclination, so minimal cusp height, flat plane teeth. That's going to limit the shear forces. We want to decrease the anterior guidance. That's going to decrease the shear forces. Reduce cantilevers, have long contact areas, so long, broad contacts, splint whenever possible, and occlusal guards. So going into the timed occlusion or the implant protective occlusion here, when we have that patient bite down very lightly, so just when those teeth, barely touch, we're not going to have any marks with our articulating paper. So this is when we're using our standard 40 micron blue articulating paper. You don't want to see any contact on that implant crown. We're then also going to check it with shim stock there. So whenever that patient's biting down, we should be able to pull shim stock through with no resistance. So shim stock's going to be about 12 microns there. We should be able to pull that with ease there, not getting any resistance. However, then when that patient bites down heavily through that articulating paper, you should still be able to pull the articulating paper through with some resistance, but you're also going to get some contact there. So when that patient's biting down heavily or they're kind of clenching their teeth, they will have very light contact on that implant crown, but you're still kind of able to pull the articulating paper through. Okay, now we'll look at the crown insertion. So now we've tested that occlusion and we're ready to kind of put the final torque on that implant crown. So this will be our last question here for the evening. So after the final screw torque, about 10% of that preload is lost within minutes. What is this screw loosening called? Is it A, the embedment relaxation, B, preload, C, torque deformation, or D, screw tension loss? Okay, very good. Majority got it there, 40% embedment relaxation or the settling effect. So if we look at this, 10% of the initial preload is lost as a result of the settling after tightening there. So whenever we insert that crown and we torque it to the 25 or 35 Newton centimeters, 10% of that preload is lost initially there. So that's why we wait 5 to 10 minutes and retighten that. That's called the settling effect or the embedment relaxation. If you are really bored one day, you can start reading about screws online and go down a rabbit hole. It's very boring literature, for engineers there. But pretty much what happens is when you get that final torque in there, the screw separates away from, or it loses contact within the internal aspect of that implant there. So that's where you lose a little bit of the preload, and we're relying on that preload to keep that restoration intact there. So that preload is going to help with the clamping force there, and that's going to be what resists the occlusal, trauma or parafunction or just, everyday life there. So that's why we have a special insertion technique here when we're inserting crowns. So we're first going to use a seating jig to insert a custom abutment. This is going to be when doing a cement retain restoration. That the seating jig is going to help not only align it, but it's also going to help it when you're screwing it in to prevent that from twisting inside the implant. And then we have a little torque protocol here where if we're supposed to torque a screw to 35 Newton centimeters, we're not going to just start with the 35 Newton centimeter torque. We're going to start with finger pressure. We'll then generally grab an X-ray, make sure it's seated. We'll then torque it to 25 Newton centimeters. and then we'll torque it to 35 Newton centimeters. At that time, you'll go leave the room, go get a cup of coffee, check a hygiene exam, and then in 5 to 10 minutes later, you come back, retorque it, and then you fill the restoration. And that's because of that embedment relaxation or settling effect. We're letting that screw lose its preload there initially, and then we're going to retighten it there. And it's kind of all throughout the literature there that, waiting about 5 to 10 minutes is sufficient there. Lastly, we'll just touch briefly here on the maintenance of restorations. Earlier, we talked about some of the complications there, but this is another study here that looked at 17 years retrospective here, and implant failures were 90% lower in patients who had regular maintenance therapy there, implant patients. So how often do we have to have implant maintenance? Are we seeing this patient every month? Are we seeing them every 3 months, every 6 months? Well, really the frequency is dependent on each situation there. So the complexity of the dental implant treatment, is it one implant restoration? Is it implants in all 4 quadrants of the mouth? Why did they lose the teeth? Did they have periodontal disease? Or was it trauma there? The cleansability of the prosthesis, is this going to be a prosthesis where they're going to be packing food constantly? Do we have an adequate sized implant in there where we're really not worried about, them packing food there? Also the patient home care there, when they come in, what shape are their teeth in? How did they lose their teeth again? And the health of the peri-implant tissues there. So these are all factors that we're going to take into consideration when developing a maintenance plan for those patients. But generally, we'll see them at least twice a year. And at least for the first 3 years, we're going to grab an x-ray of that implant just to make sure everything looks good there. As far as x-rays, it's also good to get a baseline there. So we always want to get an x-ray when inserting the restoration, because that's going to serve as our baseline down the road there. So we can track the progression of that implant and make sure you're not getting bone loss there. So in conclusion there, we covered a lot with it here. A lot goes into just a single implant restoration. First, we need to verify adequate healing there. We don't want to overload the implant. We do want to obtain accurate impressions, and whether it's conventional or digital. You also need to educate your lab. So through your lab script there, all the things that we talked about here, and also double check when the case returns from the lab there. Timed occlusions. Implants are not teeth there, so they should be treated differently. Teeth have PDL, which is able to absorb some of the force there, where implants do not. And then maintenance is key to long-term implant success. So I first want to thank ITX here for setting up this webinar tonight. They are great and truly the best in the business. They make all my surgical guides. They're very easy to work with. And this is a new kit that's actually launching next week that I've been using for the past couple months here. It's their universal kit that you can use through their surgical guides. And what's nice about their universal kit, aside from all the animals that they put on the left side of it there, is it's done without sleeves here. So this is a case that I did this week here where you're not drilling through those metal guided sleeves there. So everything is built within the implant guide there. So you're causing a lot less heat generation. You're not getting all that metal debris in your implant sites there. So truly, it's a pleasure working with them, and they do great work. We do have 3 more of these webinars coming up over the next 3 months here. So one in December, January, February, where we'll be covering full arch implant restoration. So the next one's going to be removable. So we'll be dealing with removable overdentures. The third is going to be full arch implant restoration. So a Bruxer, FE3s. And then the fourth is going to be all on X. So we'll be covering the stackable guides in that one and photogrammetry. We do have our surgical session starting up here next month here in Orlando for the Resnik Implant Institute. So those dates are online there. And then we also do have our Pros Bootcamp. This is a 3-day, very intensive boot camp where we cover single implant restorations, removable, and fixed there. We have a ton of lab components there, and we go into much more detail of everything that I covered this evening here. So thank you again to everybody. Thank you to everybody over at ITX. Are there any questions there?
Thank you,
Uh,
Christopher.
Thank you so much, Christopher. I mean, as always, an amazing presentation, and I'm so looking forward for the other parts that are coming. I think we've got one each month, and
Yeah.
you'll be covering a lot more, I know. But this one was so intense, and I learned a lot, honestly. And yes, we've got a couple of questions for closed tray impressions. Do you also had mechanical retention to the impression posts, or that's only for tray?
No, you do not. So with a closed tray impression, when the closed tray impression, you take the impression out, that closed tray impression coping is still in the mouth. You need to be able to get that back into the impression, the exact same orientation it was in the mouth. So generally, the closed tray impression copings will have some sort of alignment aid to get it back into the impression there. So the problem with adding mechanical retention is you're not going to be able to see that in detail and get it into the exact same position there. So one way that you can actually improve the accuracy, and we do this in our Pros Bootcamp, is you could take a Sharpie and mark the buckle side, and that will just help ensure that you get it in the right position there. So that's one way that we're able to, help increase the positioning of the closed tray.
Perfect. With all the modern technology and having those STLs merged to the CT scan, how much do we can actually measure from the free gingival margin to the platform of the implant? What is what is the optimum dimension from the free gingival margin to the platform of the implant when we're treatment planning on the software?
Yes, so we want 3 millimeters. That's what we're looking for from the free gingival margin. The studies have shown that's going to give you enough running room to form a proper emergence profile there. So 3 millimeters is kind of the golden number throughout the literature.
That's perfect. For an implant, is it a must to place the implant subcrestal to be able to achieve conformed gingival margin or like a gingival contour on top of the implant?
First, well, there's different types of implants out there. So there's some, such as a tissue level implant, that are meant to be placed supracrestal there. So first, it's going to depend on the implant design and the characteristics of that implant. The majority of them are platform switching now, which also helps. But generally, it's easier to create emergence profile if the implant is further below the crest there. Now, that being said, you don't want the implant 5 millimeters below the crest, but it's generally easier if it's a little subcrestal there. Additionally, with the emergence profile is the tissue thickness. So somebody that has no attached tissue, or their tissue there is a millimeter thick, you're going to want to place that implant a little more subcrestal than somebody that has 5 millimeters of tissue that you have to excise through. So those are a lot of factors that have to be taken into consideration.
Gotcha. Another question here in the aesthetic zone: do you prefer a zirconia or a titanium abutment for subcrestal implants?
I prefer a titanium. I've seen some problems with the zirconia ones, and I know a lot of people over in Europe are real big on the zirconia abutments, but I just haven't seen them where they're not going to cause complications. So one of the cases I showed there was a guy who broke off the zirconia abutment, and he was referred to me because actually part of the zirconia abutment was dislodged down in the implant. Mm-hmm. So with that, I do titanium abutments. They do gold coat them now, so you're not getting that silver hue through like you would a PFM crown. So there's ways around it there, but I'm traditionally the majority of the time doing titanium abutments.
Gotcha. I've got a couple of questions here about engaging and non-engaging abutments. In your preference, can we actually do on the same case, on the same bridge, can we combine a non-engaging and an engaging abutment in the same bridge?
Yes. So if you're doing a 3-unit bridge, there are 2 implants, you could do one of them with an engaging abutment and the other with a non-engaging abutment there. So that is one way to do it, but you don't want to have more than one engaging abutment there. So like for those 2 cases that I showed, what I actually did was I removed the engaging hex on one of those and left it engaging on the other just to allow it to seat or easier seating there. So yes, you just don't want more than one engaging abutment in a segment.
That's perfect. And I do not know if this is a thing, but do you have any thought? That's a question, actually. Do you have any thoughts on screw mentable crowns?
Yes. Yes.
Okay.
So, yeah. So,
Just the,
yeah.
the
So
term is
generally,
new.
So what I'll actually do on my cementable crowns is sometimes I'll have actually a screw access hole in there. So, I'll cement it in the mouth, and then there's actually the screw hole there, which actually also serves as kind of a vent for some of the cement to come through there. So yeah, there are, a lot of labs doing the screw mentable crowns, and you kind of get the best of both worlds with them.
Perfect. With at the time of checking the occlusion, do you have to take the abutments to full torque? Do you have to full torque them before checking the occlusion? Or I'm sorry, full torque the prosthesis?
Yes. You want that prosthesis torque to its final value before adjusting or modifying the occlusion. Yes, because that
Perfect.
implant could actually come down a little further there, which would take it further and in for occlusion. So yes.
Gotcha. With the with scan buddies, I understand that you need to take the scan with this, well, with the scan buddy in there. Do you have to take another scan after removing the scan buddy?
Yes, I think it depends on your scanner there. I use the Medit, but generally you'll take a soft tissue scan, or you can even take it with the healing cap in there, and then you'll take one with the scan body there. So generally you need two to merge. I'm not sure if that's every scanner there. I only have the Medit, so I only have experience with that. I know the iTero is the same way there, but the majority of them, you do need a soft tissue scan, or at least another scan.
Gotcha. And that's another interesting question about engaging and non-engaging abutments. Is this something that really depends on the implant manufacturer, or can we do it with any type of implants?
So every implant is going to have an engaging and a non-engaging abutment there. As far as the abutment design, that's going to be dependent on the internal aspect of the implant there. So, how deep that connection is on the internal aspect, how deep you're able to go and engage the hex there, that's dependent on every manufacturer there.
Gotcha. That's another question. Like, is it a must to do a treatment plan, like a CT based treatment plan? Would this change anything about the prosthetic outcome, or it's just only focused on the surgical outcome of the treatment plan of the cases?
It all starts with the diagnostic work up there. So ways that we can eliminate having to worry about the emergence profile is starting with a proper treatment plan prior to the implant even being positioned. So, the majority of the complications that are going to arise from improper implant positioning. So implants too far away from teeth, where you have to make a wild looking crown, or restoring implants where they're under engineered. So putting 2 implants instead of putting 3 implants, not having them in the correct position to withstand the occlusal forces. And that's where, really working with you guys over at ITX and making sure that implant is in the right spot, it really helps for, long-term prosthetic success of that dental implant. So, not everything is on, just the restoration there. You have to start with an implant that's in the proper position to kind of set you up for success.
Gotcha. And one last question, I'll let you go. Recently, I've been reading a lot of studies about splinting implants with teeth. What is your take on this one? Or combining or splinting implants with natural teeth? Is this something that we can do?
So that's going to be dependent on a lot of situations, but if you look in the literature, that's something that, if you look in 30 years of literature, it's gone back and forth, several times there. So generally, we recommend splinting to natural teeth only in kind of the worst situation there. So if you're kind of with your back against the wall there, where you can't get another implant in, let's say the patient just started bisphosphonates, and you can't put another implant in them, but they have a vital tooth, or a tooth in good shape where you can connect it to, that may be a situation there. But generally, we try to stem away from it as much as possible if we're able to get another implant in there. With that being said, unless there's, unforeseen circumstances.
Gotcha. Well, this was, like, again, extremely beneficial to everyone who attended this webinar. Thank you so much, Chris, as always. You mentioned something about the kit. So starting Monday, we will release this kit to everyone. It was just still in the testing phase. So thank you for helping us with this. We're running actually a really, really amazing offers for Black Friday. So stay tuned. We will let everyone know about this offer on Monday. And I would like to pass it on to Robert, and if you have further questions.
Thank you, AK, and thank you, Dr. Christopher. We really appreciate all the behind the work work that you do behind the scenes, and you and Tara. So we really appreciate you guys and all you do for ITX, as well as the Mish Resnik Institute. So with that, our webinar has concluded. You will be getting your CE credits in the email. And also, just don't forget, December 15th, you'll be able to, if you go to the ITX Pros website, you'll be able to register for the next webinar, which will be on the removable aspects of full arch. So with that, I hope you all have a great weekend, and happy Thanksgiving for everybody out there. So see you all.
Thank you, Chris. Thank you so much, Derek.
Great. Thank you, guys.
Thank you, Doc.